name is Kate Marquis. I'm one of the nurses at Life Support Learning Center, and today I'll be talking to you about estimated blood loss. Our objectives today are to identify methodologies to estimate blood loss, identify factors affecting the estimation of blood loss, as well as identify the physiologic factors that occur with varying amounts of blood loss. So why are we talking about it? Why is this a topic that I was asked to record and speak for you guys? Well, in terms of estimating blood loss, providers are just really bad at it. Okay, it doesn't matter if you're an EMT and it's your first day out on the job, or you're a brand new nurse, or you're a trauma surgeon with 50 years of experience. It doesn't matter. Experience level and credentials were not shown to have any effect on one's ability to estimate blood loss on scene or in hospital. Which is kind of wild if you think about it. But what's even more wild, I think, is that not only are we routinely bad at it, but a good estimation is within 20%. And now once you start getting into these larger and larger volumes of blood loss, 20% can be quite significant. Also need to kind of keep in the back of our heads that there are environmental factors that affect our perceived blood loss. So I often give this lecture to our EMTs, so they're out on scene and there's a large body of water there. That can affect how blood loss is estimated, or you come into a clinic and someone is bleeding from their scalp and it appears that there's just blood everywhere. It's all over their shirt. That can change how blood loss is perceived. There are all these different settings, and even within the hospital, big trauma comes in and there's blood all over this person. We don't know how to estimate that blood loss. So there are all these different factors that can really affect how we perceive and how we estimate blood loss. So what we've put together for you here, those of us at Life Support Learning, we've actually put together blood loss in their amounts so that you can actually see what it looks like and kind of have an idea in the back of your head, okay, this is an accurate estimation. So here we start off small. We have a 0.5 milliliter versus 1 milliliter of blood. Now these are going to go up slowly but surely in their amounts. So we've actually put pieces of paper and people's shoes in all of our pictures so that you can kind of get an idea of the difference between the two. And actually in the 1 milliliter picture, if you look, you can see the 0.5 milliliter right behind it. So you can see how it's a little bit smaller. So now we're moving up to 10 milliliters versus 1 milliliter. It's quite a difference there, but still a relatively small amount. $10 milliliters versus 50 milliliters, okay. Now we're kind of stepping up our game. $50 milliliters versus 100 milliliters. Look at the size of these blood pools compared to the shoes of these people. Okay, I think John's foot in the right there. I think he's probably a size 8 or something like that. So size 8 men's foot. Under that 100 milliliter, you can see how long that is, and how big that kind of pool is starting to get, versus the 50 milliliter one, where I believe that woman's foot is probably a size 7 or 8 in women's shoe. So you can kind of start seeing these differences here about how much bigger these pools are. 100 milliliters versus 250. Okay, so now we're starting to creep towards about a pint. So if you were to hang a pint of blood, it's about 320-ish milliliters of blood there. So we're getting into more significant amounts here. You can see how significantly different these pools are. $250 versus 750 milliliters. $750 milliliters versus a liter. Now in terms of a appreciable difference, it's starting to get a little murky. I'm just looking at that. That's a lot of blood. Our next slide will almost triple it. All right, so you can imagine thereabouts 3 of those sizes on the left there equal 1 on the right. adding an additional 500 milliliters there. And again, in terms of appreciable difference, I'm just looking at it, and that's a lot of blood. Someone's in trouble if they've lost this amount of blood. So liter difference between these two pictures. And now we're looking at basically full volume at this point. Okay, 5-ish liters of blood. That's a full person, a person's full volume at that point. If you're seeing that much blood, hopefully there are multiple individuals involved, and that's just not from one person. Again, full volume. If it's only one person at this point, that patient is probably not alive. And in order to give you kind of an appreciation for how big that puddle is, we had one of our nursing students apparently lay down so that you can see how quite big that pool is there. Factors affecting the estimation of blood loss. So I talked about this a little bit earlier when we started. There are several factors that can affect how we estimate blood loss. First one's being porous surfaces. So where is this person bleeding from, right? Is it in the carpet because they were in the family waiting room or something like that? Is it in grass? Is it in gravel? Were they at home? It makes it difficult to kind of estimate how much is there. It'll lead to an underestimation because it's porous. It absorbs the fluids here. Bodies of water tend to lead to an overestimation of blood loss. Worked in the emergency department for about 5 years, and I cannot tell you the number of people who came in and said, I've lost so much blood, and I asked them, okay, do you know how much you lost? And they were like, it was in the toilet, and it's red, and it's very scary. So this is not uncommon. And it can look rather frightening, and we'll show you a picture in a couple minutes here. Clothing may also lead to kind of this overestimation of blood loss. It's graphic, it looks scary, and I think it's just kind of the jarring picture of it that leads to this overestimation. So again, we're looking at porous surfaces here, leading to that underestimation of blood loss. If you look at that picture on the left, and if you look very, very closely, you can see little splatters all the way out on the edges of all of those rocks. So it's kind of hard to tell how much this person actually lost. Was this completely saturated? Were those just little blood splatters? Did the blood go in and underneath the rocks, because you can see that it's kind of a dirt surface underneath? Did it get absorbed into the ground? It's really hard to tell how much that person lost. Again, that picture on the right is similar. You can see that it's kind of dried out. I don't really know how much was there. Is that just a drop or two? Is that mostly water that it was mixed in? It's hard to tell. And this is the picture I was talking to you about, being an emergency department nurse. That picture on the left is only 10 milliliters of blood, and that looks particularly graphic. Even worse, obviously, with 50 milliliters. Let me show you what that looks like in those pictures again that I showed you earlier. That is only 10 milliliters of blood. Now, where is this 10 milliliters of blood coming from is probably the next question you need to ask if someone is rectally bleeding. But you can see how graphic that looks, and that's quite a small amount of blood. And this is the 50 milliliters. You can see how significantly darker it is in the toilet. And, you know, it's a nice little chunk of blood, again, coming from the rectum, but things to kind of keep in your head when someone's like, oh, I lost like a liter of blood. And you're sitting there like, probably not. Clothing here, we have this overestimation of blood loss. This looks very graphic, it looks very scary. So I do have the two pictures compared side by side for you. This is a significant amount of blood loss in this case, but oftentimes, especially in the emergency department, I can tell you people come in and their clothes are just kind of covered. You're sitting there and you're trying to figure out exactly how much they did lose because it is such a graphic kind of scene. So let's talk about tactics. How can we more reliably estimate blood loss? So we have a couple different methodologies here. Again, we are looking to be within 20% because the best estimations are within 20%. So we have a couple different methodologies. So if you're looking at a pool of blood, what you can do is you can take your fist palm up and put your fist approximately 2 inches above the pool of blood. Each fist will give you about 20 milliliters, which is wonderful for small amounts of blood, but it's really impractical if you have a very large pool of blood. You're sitting there just trying to walk around the pool of blood, trying to get a good estimation. So that's kind of difficult. This also doesn't take into consideration pools of blood on porous surfaces or in water. Again, it makes it rather impractical. Methodologies that you may utilize in the hospital would probably be utilizing chucks, and kind of similar to how pediatric nurses weigh diapers. So you'll have a chucks, you'll weigh the chucks as is, and then you'll compare it to the blood-soaked chucks. And I believe that's what they do in labor and delivery. Other things that you can do, if again this is a pool of blood on some sort of surface, there was I believe it was a Korean study, which they came up with a visual graph of blood loss, volume to area, which is kind of interesting. Again, this is more for larger pools of blood here. So you're going to actually measure this blood pool, and it's going to be based on the length of your hand or foot in centimeters. So I would measure my foot in centimeters, I would walk alongside the blood puddle, and then I would be able to estimate in centimeters square how much has actually been lost. Now again, this doesn't take into consideration blood loss on porous surfaces or in bodies of water. Again, I can't just like walk around a big old pond because there's blood in it, right? Or whatever I see on it. It's diluted. I'm going to have a incorrect estimation. So these are all different things that you can kind of keep in the back of your head. Some clearly more practical than others depending on your circumstance, but you know, sometimes you don't always have chucks available to go in and measure things out. So let's talk about shock, right? We talk about losing all these large amounts of blood, so it's really important that we talk about shock as well, because that's what happens if we don't get there in time, or if things have progressed. So what is shock? Shock, defined by the American College of Surgeons, is the inadequate perfusion of tissue such that oxygen and blood volume delivery fails to meet the cellular, metabolic, and oxygen consumption needs. Okay? It's about perfusion, right? So I need to ensure that my tissues get the blood, oxygen, and nutrients that they need so that they can do their thing. All right? They can go, they can provide energy, they can function appropriately. Hypovolemic shock, defined by the American College of Surgeons, is when the circulatory volume is depleted from blood or fluid losses. So that's not just I fell down the stairs and I broke my leg and now I'm bleeding. It's also I've had the norovirus for, you know, a week, and maybe I'm elderly and I just can't keep anything down, and now I'm in hypovolemic shock because I've been vomiting and had diarrhea for a week. The Emergency Nurses Association likes to point out that this is the leading cause of preventable deaths in trauma patients. Which is kind of wild, right? Because there's an app for that in so many ways, right? We can give volume, right? Lactated ringers, normal saline, we have blood products here. So it's really something to kind of keep it in the back of your head that this is something that we can fix, but in so many cases, it can be deadly if we don't catch it, or if we catch it too late. So let's talk about physiology. I like to think about the body as a pump with pipes, because it's easy for me to relate to. So your heart is the pump, right? And we've heard that analogy before. So what can your heart do to compensate for volume losses? Well, the heart can pump faster, all right? So you're going to increase your heart rate to increase your cardiac output. Great. And your heart can pump harder. Okay, this is your contractility. So I can jack up my heart rate, I can make my heart pump better. And then you have your vessels, who are the pipes, right? And so long as your pipes are intact, these vessels can be squeezed down. This is vasoconstriction. And if you, I like to use kids because they're a really great example. They do this so well. If you see a kid who's fluid down, significantly fluid down, you will see their cap refill go. And it's because they're squeezing down so hard. I mean, it's true for adults too. I think it's just more profound in children. But they can squeeze down so hard that they will just completely shut off that blood flow down there. And it's pretty wild to kind of see because, yes, adults do it as well, but kids just do it so much more profoundly, I think. So when we have blood loss due to a traumatic injury, we've sprung a leak, so to speak, right? Our pipes have sprung a leak somewhere. So hemorrhage is like a leaky pipe, and now we have low water pressure. Right? So I have volume and it's circulating around, but it's leaking out, and my volume, my pressure is not as high. So again, talking about our cardiac output, stroke volume times heart rate. So how are we going to compensate for this? We're going to jack up our heart rate. Right? We're going to improve our contractility, and we're going to vasoconstrict. Right? These are all the things we just talked about. Now, the problem is that we have low water pressure. So what happens when I jack up my heart rate and I have a leak in my pipes? I'm going to start having a more significant leak, right? Because now that blood's being pushed around faster, and I'm still leaking. I still am losing blood. All right, and now I'm probably losing it faster. So we need to do two things here. We need volume replacement, right? Because we have low water pressure, and your body is realizing that. So that's why it's compensating. And we need to stop the leak. Outcomes are significantly better when we stop the leak, as you can imagine. All right, and the sooner we stop the leak, the better. Because if I don't stop the leak, eventually you're going to do what we like to call it in EMS, in the emergency room, is you start bleeding pink, right? I've given so much normal saline, so much lactated ringers, that everything is diluted out. All my blood is diluted out, and you're bleeding pink. You're not bleeding red anymore. Okay. And keep in mind, what is the oxygen carrying capacity of normal saline or lactated ringers? 0. The answer is 0. All right, so there are other things that we need to replace in order to help your body stop the leak, or help that person's body rather stop the leak, right? Those clotting factors and all of that, and then dealing with the shocky aspect of the hypoperfusion of tissues. So this is Starling's Law. Starling's Law states that at some point the ventricles will not have enough time to adequately fill because the heart's beating too fast to compensate. This causes cardiac output to fall, and the body can no longer compensate. Okay, so again, your heart rate is responding to that leaky pipe, and it starts beating faster. Eventually, it will beat so fast that the ventricles aren't filling enough, right? And that causes your cardiac output to fall. So there are several flavors of shock. Okay, and we're going to talk about each one. First one is compensated shock. Now this might be subtle. Okay, and this is very important because people don't realize that patients are in shock right away because it's so subtle. And it's really important that we respond as quickly as possible and as soon as possible in order for these patients to have better outcomes. The sooner you realize it, the better. Okay? Now it might just be something as simple as, yeah, their heart rate is just a little bit up. Their blood pressure is just a little bit down. Their respiratory rate is just a little bit up. It sounds like we got a case of the littles, guys. Because all those littles mean that something big is probably going on, and this patient may be in compensated shock. In order to be in shock, your blood pressure doesn't have to be, 80/60. It can be something as simple as, now their blood pressure is like 110/70, and it was like 130/85 before. Right? In compensated shock, oxygen is being shunted to the brainstem, and things are being and this oxygen, as it's being shunted towards the brain, things are not getting as much oxygen as it usually would, because your brain is kind of like this tantruming 2-year-old, right? If you think about a 2-year-old, they can't store anything. It doesn't store oxygen, doesn't store nutrients, and it wants what it wants. It wants it now, right? So it's greedy. It likes to have all the oxygen, which is why you see this decreased urinary output. Now, what's narrowing pulse pressure? Narrow pulse pressure is if the difference between the systolic and the diastolic blood pressure is less than 25% of the systolic value. And this is due to a drop in the stroke volume. Okay. So if someone's blood pressure is 100/75, the difference between your systolic and your diastolic is 25, which is in fact 25% of the systolic value. A narrowed pulse pressure would be like 100/80. Okay, you can see how that is now less than 25%. Why does the respiratory rate increase? And again, that's coming back to talking about the brainstem here. So we have lost oxygen carrying capacity for whatever reason. So now your body's trying to compensate by breathing more to shove as much oxygen, if you will. I like to think about it as seats on a bus. It's not really seats on a bus, but it's a nice way to think about it. Seats on a bus, so instead of having, like my 10 passengers on my bus, I'm going to try to shove 15 passengers on my 10-person bus in order to have my tissues be adequately perfused. Talking about decompensated shock. This is the failure of our compensatory mechanisms. Okay, now our patient is lethargic, they're hypotensive, their pulse pressure continues to narrow, they're tachycardic, they have these weak and thready pulses, especially when I compare my distal to my central. Again, tachypnea, my respirations are now shallow because they're breathing so fast, they're cool, they're clammy. This is textbook kind of what we think about when we think about shock. Be mindful that shock has already started and had started a long time before this happened. Okay? Our compensatory mechanisms have failed at this point. Now, luckily, this is still reversible. Right? It's when we start to get into irreversible that we get into trouble. And really, if we don't respond quickly enough to decompensated or even compensated, our outcomes vary there. You want to find this as early as you can, but irreversible, death is imminent without immediate intervention. These patients are obtunded, right? You have a terrible time trying to rouse them. They're hypotensive. Their respiratory rate has actually decreased, and it's shallow. It's a little frightening looking, right? Because we saw how high it was getting before. They're cool, they're clammy, they have coagulopathies, they have dysrhythmias, they're in multiple organ failure. And eventually, all of this leads to death. Right? Kate, why do they have coagulopathies? This is due to disseminated intravascular coagulopathy due to the loss of clotting factors. So what happens is the body throws all of their clotting factors at whatever is causing this volume loss. So again, taking the example of broke my leg, broke my femur, and now I've torn one of my great vessels. My body's throwing all these clotting factors at it, and the bleeding's not stopping, and eventually I'm going to run out of clotting factors. All right, this patient needs platelets and other things, which is why we talk about a balanced resuscitation, and why our fast blood has actually moved to a more balanced resuscitation. How do I determine the stage of shock? I don't know if you've seen this clip before. This is the just look at him guy. So I would YouTube just look at him. We want to take a look at our patients because they will give us a clue to kind of where they are. The American College of Surgeons has this nice happy little table here that kind of goes through the different volume losses and kind of some of the things that you can see. What I want you guys to keep in the back of your head is this really kind of key component about vital signs. all vital signs are points on a graph. And if you think about it this way, it might be helpful. They allow you to trend where your patient is going. All right, so again, talking about my patient whose heart rate was 80 when they came in, and now it's 85, and now it's 93, and now it's 110. I mean, those are just little blips, but if you look at it kind of on that whole curve, I can see that my patient is starting to decompensate, or they're starting to compensate, right, for something. Why is their heart rate going up, right? My patient's blood pressure is 150 over 85, and now it's 142 over 87, and now we're kind of creeping down into 130 over 90, and now I can see that my patient's blood pressure, first of all, is a narrowing blood pressure, right? But additionally, my blood pressure is kind of starting to fall, right? These are points to help you figure out what way your patient is going. And that's really important, because by identifying this, you can now go in and say, hey, my patient's not going in the right direction. I need help, or I need to tell the physician, or I need to do a MET call because they're not going the way they need to go. They're trending wrong. Something is happening, something bad is happening, and I need to phone a friend. Right. So let's talk about the American College of Surgeons here and all of their classifications. Class 1, volume loss is between 500 to 750 milliliters, which can be about 15% of blood volume. That is just wild. And you can see the difference between those two pictures down below. All right, we're talking at least a pint. So if you guys think about when you hang blood there for a patient, say, that's about 320, 330-ish milliliters of blood. So you're looking at about 2 of those potentially. And kind of the things that we're looking to see is that narrowing pulse pressure. Okay, that systolic minus that diastolic, and when it starts to creep. Class 2, 750 milliliters to 1500 milliliters. Now we're getting up to about 30% percentage of volume loss. Again, this is an extraordinary amount. You're going to see increase in heart rate and an increase in respiratory rate. Urine output is going to be decreased again because we're shunting all of that blood kind of away from the kidneys because we want to send it to the vital organs. People are going to be anxious. I would be anxious, especially if I saw that much of my volume outside of my body. But they're going to be anxious because, again, it's an oxygenation thing, so they're not oxygenating properly, so that makes people anxious. They may be cool as well. Okay. Things to kind of keep in the back of your head: mental status changes can be indicative of a myriad of different issues. So is my patient anxious because they've now had some volume loss and they're not oxygenating appropriately? Maybe they're not perfusing appropriately because they have a dysrhythmia. Maybe they're not breathing properly. Are they having a stroke or some sort of neurologic event? These are all different things that you kind of want to think about when people start to get anxious. And I wouldn't just necessarily chalk it up to psychiatric off the bat. I would look for that actual underlying cause before you start writing off anxiety. Class 3, volume loss, so 2,000 milliliters. If you guys think of a 2-liter Coke bottle or 2-liter Pepsi bottle, whatever your preference is, that's how much volume of blood that someone has lost at this point, up to 40% of their blood volume here. Again, you're going to see vital sign changes, increased heart rate, respiratory rate, and a decreased blood pressure. Okay, we are moving towards decompensated shock at this point. Right, the urine output has dropped off the floor. You see a significant decline in their mental status, and they have slow cap refill. Again, that's kind of hard to tell on adults because it's just not as good on adults. They're cool, they're clammy, they have pallor. They're looking bad. They're looking bad. Class 4, and this is greater than 2,000 milliliters of blood. This is greater than 40% of someone's blood volume. Again, you're going to see mental status changes in that they're lethargic, they're cooled, they're clammy, they have pallor, they're little to no urine output because everything, all their blood flow is being shunted elsewhere. All right, this is not an insignificant amount of blood to have lost. Again, being wary of the decompensated shock. Right, so we want to kind of get these things early so patients have better outcomes. Shock indexes are a relatively reliable way to kind of figure out where your patient is in the grand scheme of life, and they're relatively easy to calculate. I'm not terribly good at math, but I do have a calculator on my work phone, so I use that often. So what this talks about is that heart rate, systolic blood pressure, and diastolic blood pressure alone aren't reliable indicators of shock. And you saw that in the American College of Surgeons classifications. You know, it's just not necessarily, oh, their heart rate's up, they must be in shock. That's not necessarily true, right? We're looking for that case of the littles because we want to identify this early. We want to identify this while they're still in compensated shock so that they don't progress into decompensated and irreversible shock. So there are 3 different shock indexes that I have for you today. The regular shock index, the modified shock index, and the age shock index. These are found to be more sensitive because they take a variety of factors together to kind of give you an idea of these early warning signs of hypovolemic shock. So the shock index is the heart rate over the systolic blood pressure. If it's equal to or greater than 1, so they're in a hypodynamic state, which means that they may be in a shocky kind of flavored state. Modified shock index is your heart rate over your MAP. So greater than 1.3 indicates a hypodynamic state and increased morbidity and mortality. Again, this is when someone is fluid down, that hypodynamic state, so they don't have their blood volume is not where it should be. And what I like about this one is that it indicates an increased morbidity and mortality. So that means we may be behind the 8 ball and we need to really start moving quickly. The age shock index is valid in geriatric patients. This is age times your heart rate over systolic blood pressure. So I'm calculating what the heart rate over the systolic blood pressure is and I'm multiplying it by their age. Equal to or less than 50 indicates an increased morbidity and mortality. Special considerations. All right. I don't know how many of you guys know of Looney Tunes. I'm a big fan of Looney Tunes. I grew up watching Looney Tunes. So for those of you who don't know Looney Tunes, I suggest you Google Wile E. Coyote. Wile E. Coyote works with the Roadrunner. He keeps trying to catch the Roadrunner, and the Roadrunner is very fast, i.e. his name is Roadrunner. So Wiley comes up with all these different methodologies to try to catch the Roadrunner, usually rockets. He's a big fan of rockets. So he will strap a rocket to his back and he'll try to catch the Roadrunner. Unfortunately, the Roadrunner can stop on a dime, where Wiley cannot with a rocket strapped to his back, and often ends up going off a cliff, as you can see here in this picture. He'll usually flash a little help sign, and then he falls into the canyon below. These patients are very much like Wile E. Coyote in that they are really, really great at compensating, and then they're really not. So, you know how adult patients, if you look at them, they compensate, and it's just kind of this gradual decline. These patients, instead of having that nice gradual decline where we can kind of go in and react, and if we catch it too late, we can react to it, these patients will decompensate very, very quickly. Okay, because they're so good at compensating. So I'm going to start out with our pregnant patients. So for those of you going to labor and delivery, these patients are hypervolemic and hyperdynamic to begin with. Okay, so they already start out kind of fluid up. Things to kind of keep in the back of your head, that pregnant patients can lose up to 30% of their volume before you see a drop in blood pressure, which is kind of scary. We saw how big of a volume that 30% can be, right? So that was what, 1,500 milliliters, thereabouts. It's a lot of blood. Additionally, their resting heart rate is also higher to begin with, so you're looking at 10 to 20 beats a minute. The hypercoagulable, and then we need to kind of keep in the back of our head this supine hypotension that they can have. So for those of you who don't remember quite labor and delivery, supine hypotensive syndrome is when the baby's resting on the aorta and the inferior vena cava. So you actually need to turn this patient onto their left side so that they don't get super hypotensive. Other things to think about, because baby is down in that pelvic region, there are engorged pelvic vessels because they're providing blood flow, right? These engorged pelvic vessels can increase the risk of retroperitoneal hemorrhage, which is not easy to see on a regular day, never mind when there are, children in the mix. And again, this patient is hypercoagulable due to the increase in fibrinogen and clotting factors, which puts them at risk for thromboembolism and DIC. Just in general, trauma patients are 2 times as likely to develop a PE or a DVT than a medical or a surgical patient. So, the pregnancy plus a trauma, this patient could be in a really bad way very quickly. Moving on to my munchkins, pediatrics. Pediatric patients, their compensatory mechanisms differ a little bit. They are really, really, really good at vasoconstriction and increasing their heart rate. And this is mostly to compensate for the fact that they're really terrible at improving their contractility of their heart. So they will rev their heart rate up so high, they will clamp down on all of their peripheral vessels, and it's very profound, but they're really terrible at contractility. So just kind of keep in the back of your head, this kid starts ramping up very high. Eventually, Starlings Law states that their stroke volume is going to drop. Keep that in the back of your head. Hypotension also occurs after approximately 30% of volume loss. This is a sign of circulatory decompensation and, going towards collapse. 30% is very significant. You got to think less blood, smaller person, they have less blood in them, so 30% is a smaller volume as well. So kind of keep these things in the back of your head. And if you start seeing drop-offs in their blood pressure, you could also be behind the 8 ball. Also keep in the back of your head that vital signs differ with age. So I have personally a little card that gives me the normals for different age groups. I like having that card because I, as a pediatric emergency department nurse, I work with a myriad of age groups there. So just kind of keep that in the back of your head, that a heart rate of 150, 160 in an infant is significantly different, and is normal, than a heart rate of 160 in a 10-year-old child, or even an 8-year-old child. So kind of things to keep in the back of your head. And definitely utilize cap refill. That's a really great indicator in children as well, kind of where they are in terms of their circulatory status. For the rest of you guys, elderly, you can see a larger percentage of a population within hospitals are geriatric patients. So the Emergency Nurse Association has this really great point here. At baseline, there is a limited ability to increase heart rate and cardiac output in response to physiologic stress. That's because left ventricular thickening decreases in pacemaker cells in your SA and AV nodes. These decrease your filling capacity and delays your filling time. You have muscle mass reduction and atrial stiffening, which decreases your contractility. Anemia is a big thing in the elderly patients caused by nutritional deficiencies, chronic inflammatory diseases, chronic renal diseases, and hypoperfusion may be poorly tolerated due to declining cardiac reserve. Right? So just in general, physiologically, they're at a significantly higher risk because they can't compensate as well. And then on top of that, we add things that knock out their compensatory mechanisms, such as beta blockers. How does someone ramp their heart rate up to compensate if they're on a beta blocker? The answer is they can't. All right. Typically, high blood pressure may cause compensated or decompensated shock to appear normal. This is why it's important to trend. This is why a case of the littles can really mean that the patient is in big trouble. All right, so, oh yeah, my patient's blood pressure is, 120 over 80, like we're good. No, not when their normal blood pressure is 160 over 100. They may be decompensating on you. Why did their blood pressure drop off? Did you give them something to cause it to drop off? Or is something more sinister afoot? I had a patient in the trauma bay. Actually, we were in CT scanner, and I was watching the patient's heart monitor, and their heart rate was 100. I'm like, okay, I'm not happy about it. I'm not terribly upset about it. That's fine. I looked down to grab a pen out of my scrubs or something like that. I looked back up, and their heart rate was 60. Okay, I didn't do anything to change that heart rate. Right? I didn't give any kind of blood pressure medication to drop it down or to lower it, no beta blockers or anything like that. I didn't do anything. That patient coded shortly thereafter. These are things you need to kind of keep in the back of your head. Why did this trend happen? Why did this change happen? Is it consistent with my trends? Is this a good trend? Or am I worried about this? So let's talk about your assessment. Okay. When you go in, before you even touch the patient, you're going to do what we like to call an across-the-room assessment, an approaching assessment. If you work in pediatrics, we call it an across-the-room assessment, or you utilize your pediatric assessment triangle. And what you're going to do is you are going to see if you need to reprioritize to see ABC. Okay, I'm looking at my patient, are they acting appropriately? Are they breathing? Are they breathing is an okay question. That's a question I ask myself all the time as I'm approaching the patient. Are they breathing? Are they breathing too fast? Are they breathing too slow? What's their circulatory status look like? Do I have any gross bleeds? Do they not appear breathing and they're not talking to me and I might need to consider CPR? These are all things you want to think about. So if they're alert and talking to me and I don't see any gross bleeds, I can go ahead and do my airway, breathing, circulation in terms of my primary assessment. But if they're not, I need to assess for gross bleeds. I need to look at my central and peripheral pulses. Do I have them? Do I need to start CPR? And I'm looking at my skin color, temperature, and moisture. In this case, if you see someone has a massive bleed, you're going to start with CABC. So you go in and you do your circulation assessment, then you do your airway assessment, then you do your breathing assessment, and then you come back to your circulation assessment. Okay? Because we like to think about our nursing process and we can really kind of narrow it down to three aspects here. You're going to look for a problem. When you find that problem, you're going to act on the problem. And then you need to reassess, and that point is missed by so many people. New nurses, old nurses, doesn't matter. You need to stick to this process of looking for a problem, fixing the problem, and ensuring the problem is fixed, and it stays fixed. This is why we do multiple assessments a shift. Okay? You need to ensure that you have in fact fixed the problem, because if you did not fix the problem, or if the problem gets worse and you need to fix it again, you need to actually go back and fix it again, right? So if I have a patient and they're snoring, and I do a modified jaw thrust maneuver, and it opens their airway, and or I reposition their head, and now that I've repositioned their head, they stop snoring, we're good. I need to come back eventually and see if they're snoring again. Because if they're snoring again, I might have to do a jaw thrust maneuver. I might have to put in a nasopharyngeal airway to ensure that they have maintained that airway. I may have to escalate that, even if they don't have a gag reflex, to an oropharyngeal airway and start talking to my physicians because now my patient's not maintaining their airway. In terms of trauma assessments, the ABCs are any kind of assessment. The ABCs are imperative. In terms of the trauma assessment, your CABC or your cardiac arrest assessment. CABC, that's where you're going to start. And then you're going to move on to your disability. Is my patient lethargic? Are they responding appropriately to me? What's their blood sugar look like? And then going to E for exposure. And I talk about E for exposure here because you need to see if there's anything else kind of going on, especially in your trauma patient. So what we'll do is we'll make the patient what we call trauma naked. You don't get any more naked than trauma naked. To see if they have any other wounds or if they're bleeding anywhere else that we need to kind of know about. Because I can see if my patient's decompensating, but I need to go in and find out why they're decompensating, and maybe their thigh is huge now. Why is their thigh huge? Well, because, you know, they've wrecked a major vessel because they have a femur fracture, and now we need to kind of go and figure it out from there. I need to identify that they're bleeding there. Be wary if you're turning and moving a patient because you may dislodge blood clots and cause patients to rebleed, so just kind of be wary of that. In terms of interventions, we need to intervene early because the earlier we intervene, the better the patient outcomes are, and we need to stop the bleed. We are doing a balanced resuscitation ratio of 1:1 plasma to product. So you can start out with 1 to 2 liters of fluid, and then you're going to escalate to blood products, so red blood cells, plasma, platelets, and the new mass transfusion protocol and fast blood protocol reflect this move towards a balanced resuscitation ratio. So I would go and check out all that new stuff from our blood bank that just came out. We want to keep our patients warm because we get worried about the trauma triad of death, which you can see on the side of your screen there. Hypothermia impairs thrombin production and platelet function, so it impairs their ability to stop the bleed themselves. Acidosis also impairs thrombin production, and then coagulopathy, this results in the depletion of clotting factors through hemodilution and the impaired ability to produce clotting factors, so we're basically rendering them unable to stop the bleed themselves if they kind of get into this way. So we want to be mindful that we keep this patient warm in order to really give them the best chance at outcome. Please keep in the back of your head that balanced resuscitation ratio, very, very important. We're not going to just throw 1 million liters of fluid at them because the oxygen carrying capacity of normal saline or lactated ringers is, yes, 0. Right. In terms of munchkins, we're going to do 20 milliliters per kilogram of fluid for their boluses. And then when we move to blood, and these are this is saying that the child is healthy and does not have an underlying heart condition. It's very important for me to mention. Then we're going to do 10 milliliters per kilogram of blood. Those numbers do change if the patient has an underlying cardiac condition. All right. So that's all I have for you guys. I really appreciate you taking the time. If you have any questions, my email is kem7yd@virginia.edu. Happy to answer any questions for you. I hope you have a great day.